Okay. All right. Miss Rosa, we are live. Welcome
Hello.
to Tea Talk. We're excited to have you here. I know here's the thing, right? We first reached out to you to speak at our Seek workshop as we're scrambling
Mhm.
in Memphis. But listen, even though you're not speaking at the next one, we have you down for a future one in Memphis. I forgot which month we get back there, but in any event, we're looking forward to that. But
Yeah,
today, we are happy to have you on this show to talk about health inequity,
yeah.
just as you see it. And the interesting thing is that you work primarily with HIV patients.
Yes, ma'am.
But health inequity is health inequity. Doesn't matter if you're HIV, cancer,
Mm-hmm.
whatever it may be, it's just health. And
Yes.
so I know that we are going to have people on the replay. And if you've missed the live, I want you to ask your questions in the post anywhere on the replay because we're going to answer them as we go along.
Yes.
So Rosa, introduce yourself and your PhD candidate, holistic
Yes.
medicine. Tell us where you're located and what you do.
Yes, ma'am. Hello, everyone. I am Rosa Barber. I am located in Memphis, Tennessee. I am currently obtaining my PhD in holistic medicine. I also have my MPH in public health with a concentration in population health. Have my bachelor's in health science. So as you can tell, I am a big health fanatic and community advocate and educator. So thank you all so much for having me.
Absolutely. How did you're in the HIV space. What started that journey?
Yes, so I was originally in pharmacy school, and me, as you can tell, I'm energetic. I'm a people's person. I'm not a person who likes to be tied down to one location at you for 12 hours at a time. So I dropped out of pharmacy school and I was like, there has to be a way that I can reach the masses and reach my community and do what I love. And so advocacy, my sister had a nonprofit organization which is called Partnership to NA Status, and I was like, I started volunteering and just meeting new people and hearing stories and hearing testimonies, and I was like, this is my ministry. So I went to school and I was like, let's do it. And I went all those years of pharmacy school. I went back to school, got on my master's, and then I was like, I'm going to further this along. And so now I'm doing my PhD in holistic medicine because I want to be able to treat the whole person, or research to help physicians and those who treat people medical in the medical field physically, hands on. I want to be able to provide them with research to treat the person holistically and not just focus on one thing when it comes to a person's health.
Okay. When we were talking earlier, I thought it was so interesting because you're working with HIV
Yeah.
patients, you're working, with trans and so
Yeah.
forth. And we talked about how sometimes it crosses into cancer because you look at the whole person. We look at
Yes.
HIV as an HIV issue, but
Yes.
we're not looking as a person issue. So give us some stories as to what you're seeing out there and how is what are you seeing in terms of health inequity, especially for the population that you serve?
Yes. Yes.
Tell us what you're seeing and what you are doing about it, because I know you mentioned that you've worked with the mayor, you've worked with the Department of
Mm-hmm.
Health. So
Yes.
what are they doing to address it, and how do you see? We talked also about health inequity or
Yes.
health equity versus health equality. So I know I'm throwing a
Yes.
lot at you, but tell us what you're seeing out there, because you had some really interesting stories that you
Thank
were sharing with
you.
me earlier. Yeah.
Yes. So, as I said, advocacy is my ministry. So when I'm out here fighting for people who look like me, especially, I'm trying to get everyone to look at the larger picture. So when people look at my resume or they look at the organization that I work for, they immediately just focus on HIV/AIDS. They forget about an entire person that has mental health, that has physical, emotional. Their parents, they have a life outside of just their diagnosis alone. And so, like I said, we work with LGBTQ individuals, and most of the time when we're dealing with trans women, they identify as women. They are women. And so most of the physicians or the people, we try to teach them competency, because they fail to realize that you have to treat the entire person, meaning that although they are women, they may have not had sex reassignment surgery. So they are still having to host in their body a prostate, and they're not getting their regular, like we will go into the doctor and we get our regular breast exams, we get our regular pap smears, all of these things. And so they're not getting their regular prostate exams. And physicians forget this. And so it's not a conversation, because they're not going to bring it up. They're not men, they're women. And so that leads to untreated cancers that that's preventable, that they die from. It leads to a host of things. They forget about diabetes. They forget about hypertension, especially being of color. That's a whole different spectrum alone when you're of color. And so that's what I try to fight for every day, to say, look at the entire person. Don't just look at their diagnosis. Okay, we understand they have HIV, but once we treat the HIV and get that under control, we have to get everything else under control also. And so, it's just not taken seriously. And I guess people are just one track minded. But when you're entering into dealing with a person's health, you have to look at the entire person, and you have to listen to their where they are, gauge where they are with their health, gauge the education. And so you and I was speaking about health equity and the health equality and the differences, and most people don't look at the differences. And so what I was saying was, I could go into the doctor. This is health equity. I can go into the doctor, and because I have insurance and my cohort doesn't have insurance, I'm paying $500 more for the same exact care that I'm getting as my cohort. But with equality, we're able to. I can go into the doctor and say, hey, I'm having things. Me being a born woman, cis woman, as they will say, I can go into the doctor and express, because trans women have breasts. We also have trans men who still have breasts. They have not had the reassignment of surgeries, or have not had the reductions yet. So they are at risk of breast cancer. And they don't want to talk about it, because it's all about comfortability, and by all means, but we have to be realistic and present those options of, you still need to be checked, because men get breast cancer. It may not be as common as women, but it's still at a risk. So even though I'm going into the doctor, the equality part is, a trans man or woman should get the same quality care as I get with those breasts, that they need to be checked, and have the same serious conversations that we're having all the way around. So that's the difference that most of our people forget when they're having the conversations, when they're interviewing a new patient that's coming into the office for the first time, or or it's repetitive, these conversations that's not being had.
Yeah. Interesting. I mean, when you mentioned earlier to me about the fact that, the in the trans world, where they're not, they haven't fully transformed.
Yeah.
So they're ending up with things like, on one end, prostate cancer,
yes,
on the other end, breast cancer,
yes,
for the same reason. It's just we need to educate. We need to educate the doctors, because, and how is that? I mean, how hard is that? I know you mentioned that you work with the Department of Health. You also work with some physicians. Are they receptive to what you're saying? I mean, let's just be honest.
Yeah.
We're trying to address health inequity, health disparity, social determinants. We're trying to do all these, but are we making progress? is anyone listening? You said you work with the mayor. When you work
Mm-hmm.
with the mayor, is he or she making any changes? Is the
Yeah.
Department of Health putting in programs? I mean, how are we addressing the disparities down there in Memphis?
Um, yes, so there's no secret we're in the Bible Belt. We're in the South. People don't our leadership does not like to have these conversations. And so, yes, that's the whole entire point of us working with our leadership, especially those who create funding or approve the funding for us. And then in turn, working with physicians and, doctors' offices to try to make everything inclusive. I would say we are further along than we were 5 years ago, but we still have a way to go. And I say that because there's no secret about what's going on here in Tennessee when it comes to gender affirming care, when it comes to African American or Spanish speaking individuals of color who goes into a doctor's office and isn't taking it serious as our white counterparts when it comes to pain, when it comes to expressing a need. Say there's a new they're on a new diabetic medicine and it's like, hey, I need it's making me dizzy, and well, you just gonna keep taking it until you feel better, whereas our white counterparts could go in and say, hey, I'm taking this new diabetic medicine and it's making me feel dizzy, and so they're giving other options. It's and then even with pain medicines, women, like we was discussing earlier, black women, we are strong. I don't want to be looked at as strong. I'm strong, but look at me as I want compassion when I come to you and tell you I don't want to be battling cancer or battling some kind of chronic disease and lupus, anything that's chronic that African American people suffer with. And oh, you okay? Go take a Advil or a Tylenol. This is chronic pain. Whereas my white counterpart here, especially here in the South, our doctors do not take us serious when it comes to pain. I do not want to be the strong black woman. Please show me compassion when I'm in pain, because you are between myself and death, or
Right.
myself, and because that affect, when you're in pain, it affects your mental health, it affects your emotional health, it affects your self-esteem, it affects your marriage, your ability to be a parent, all of these things. And so people, like I said, they don't look at the holistic person. So we are way further than we were 5 years ago, but we have a way to go when it comes to health equity and equality here in the South. And so what I try to do is I try to keep our leadership educated on data, showing them like this is what's happening, this is what we see working. This is what needs to continue happening. Sometimes it doesn't work because money talks. And so
Right.
if they feel it's out of the budget, they don't want to talk about it, it's gonna be left alone. But I do I would like to say, and I don't mean to offend anyone, but when different ethnicities and races come together, when it affects them personally, you get different results with different things that you fight for. So if it's affecting African American women, we're not going to get as much of a fight because sometimes we just are quiet because we don't know how to fight for ourselves. Whereas our counterparts, they're going to know how to fight for themselves, and they're going to get what they need. And it's going to be some laws passed. It's going to be some revisions. It's going to be some money available. It's going to be something happening. So we just need to start being our own voices and start being the voices for our people who look like us, no matter where you fall at on the ethnicity spectrum or race spectrum.
Well, Rosa, I'm certainly glad you're in my corner. I'm certainly glad you're out there speaking for the people in Memphis because, you're walking the talk, you're living it. You and I shared something before we got on the call on the live, about your own and I'm going to bring it up here if you don't want to.
Yes, no,
Your own personal experience going to the doctor and what you experienced,
yes,
which would not have been experienced by someone else,
yes,
because of that misconception that that black women are very strong and so
yes,
have the same pain with a higher pain tolerance. I mean, if you
yes,
stick with a need, I'm going to feel it, right? I mean,
yes,
I'm not quite sure where that came from, but
Yeah.
it certainly shows up like when you went to the doctor
Yes.
and you were treated, different. I don't know if you want to share that or you want us to move along,
Yes.
but
No, no, I can because I wanted to. I've lost two friends over the past 2 years due to childbirth, and they were both women of color, and it could their death could have been prevented. And I was sharing with you that yes, I had a miscarriage, and I also had when I was giving birth to my children. But the thing that stuck out to me, I was just telling one of my friends this when I was having my daughter. I expressed to the nurse, hey, I feel her head. Like, even though she came and checked, birth moved fast. And so I was like, I feel her head. It's coming delayed. Oh, the nurse, no, no, you don't. But I was actually having my child on the bed, and that could have been life threatening for myself as well as my child. And then, like I was expressing to you, when I went to the hospital, when I was experiencing a miscarriage, my pain was not taken seriously. And like I said, I'm vulnerable at this time. I'm miscarrying. My heart is breaking because I'm losing my child on top of me being in physical pain. So I'm in emotional pain. I'm in physical pain. And then I'm having a battle with my doctor who's supposed to be there taking care of me. And anything could happen when you're miscarrying. You can bleed out. You will hemorrhage. You can, anything, especially black when we have preeclampsia, which takes us out really quickly. And no one wants to listen to us, but where our counterparts are expressing that pain, they get so much more compassion. And we know that comes from our ancestors. They had to be strong. And then what we had to endure with America 400 years ago, whatever the case is. But this is a new generation and age, and I just feel we're all human. If you pinch me, I'm gonna feel that same pain as if you pinch a baby. I'm not strong. I'm not strong, especially when I'm vulnerable. We're all vulnerable at some point. And even with men, we have to be cautious when we come to them, even at sometimes, because we forget to have that conversation. Men are vulnerable. And so with the data, with suicides, with them being quiet and holding in pain, but they're dying. And so they have massive heart attacks. They're dying from cancers or diabetes because they won't go to the doctor because they don't want to look weak. And so it's just a massive conversation that needs to be had, United States and Southern and everywhere, about the different spectrums when it comes to health and equality and equity and all of those things.
It's a lot, Rosa. It really is. I'm
Yeah.
going to take some questions from the audience. It certainly is a lot. Let me just go through some questions here.
Okay.
Ilana said, living in Memphis, do you see health disparity as an ongoing issue unique to Memphis, or is this a fight going on across our country?
Yes, so living in Memphis is targeted. It's a focus because I'm here in Memphis. But I see it uniquely to Memphis, but not only to Memphis, I see it unique in all southern states. So there's Texas, Alabama, Florida, the 13 colonies, I would say, every southern state, I see it as unique. Whereas if I go to California, it's so progressive where they're offering opportunities for health equality. There's not too much disparity because they try to catch it before then. In New York, there's health equity. It's different places that want to go forward with making everything equal for each individual to make sure. It's just the South is kind of slow with catching up, and I don't know if it's funding. I don't know if it's because we're religious here or what it is. But like I said, there's a conversation that needs to be had. So I do think that the South is unique, whereas I do see the focus on Memphis, but I think it's the South as a whole that's unique with health disparities.
Great. Thank you for that answer. Sarah says, we carry so many identifiers and they overlap. Should you get to know some basics before beginning to communicate? So I think she was putting this question there when we were talking about when, in the trans community.
Yes.
When they go to the doctor. Okay. it goes
Yeah.
back again to education. And I know you're working with physicians. Like,
Yes.
what are the questions we're supposed to ask when,
Yes.
when someone presents? Maybe, are you trans, or did you
Yes.
complete your, your transformation?
Yes.
Things that will help. When was your last whatever test, right?
Yes. Yes.
Prostate screening or breast screening, because
Yes.
people are dying because while they're transitioning, they're not trying to identify with what they're moving away from.
Yes.
They're
Yes.
denying who that other part was. So if you're a man transitioning into a woman, you don't want to talk
Hmm.
about
You
prostate.
don't. Yeah.
And if you're a woman transitioning over to a male, you don't want to talk about breast health. And so
Yes. Yeah.
we need to get more, even on the
Yeah.
intake sheets
Yes.
before we
Yes.
proceed.
I was
What would
gonna say
you
that.
think?
Everyone's journey is different. There's
Yeah.
some trans women who has been transitioning for 30 years. There's some who's just coming out and they may still have facial hair, but they wear a wig or something. So just being not being judgmental or looking at the book before you
Yes.
read you not looking at the cover of the book before you open it. So asking questions like, what are your preferred pronouns? What's your preferred name? Asking when was the last, and then you can go not so much as on the paperwork. You can do those affirming things in the beginning.
Mhm.
But when you get into the medical room, you can go deeper and see when was the last time this happened. I know you don't want to speak about this, but we need to talk about this. When was the last time you had a prostate exam? When was the last time you had a breast exam? When was the last time you've been tested for diabetes or heart disease? What are your family histories? I understand you don't want to identify with that, but I think in the beginning, if we're more open in the beginning, so they don't feel shut off
Right.
with the paperwork, because a
Right.
person can feel some type of way when they're doing their paperwork and not feeling overwhelmed with that, then it could lead to open transparency when you get into the room alone and be able to have conversations. We like to call it client based interviewing. So giving them the floor to tell you everything they need to know, and you just having an open ear and an open mind to accept it so that you can get them the help that they need.
I mean, I am loving what you're saying, Rosa. And I'm, I know you say you work with the Department of Health and you work with the
Yes.
physicians. Are you advising them on how they could perhaps redo that paperwork? Because you're right. When you go to the doctor, you could feel excluded by how the
Hmm.
questions are written,
Yes.
right? It could feel discriminatory, it could feel weird. And
Yeah.
so, are you doing, or do you know anyone in Memphis doing that kind of sensitivity training, that
Yeah.
kind of like, okay, let's analyze how we're doing things.
Yeah.
Now, there was some progress made over the last 5 years. It's not
Yeah.
area, but I love any kind of progress. We may
Yeah.
not have arrived, but I love that there is some movement, because
Yeah.
if you said to me, we have not changed in the last 5 years, it'd be extremely discouraging. But
Yeah.
you say there's some progress being made.
Yes.
At least I feel like someone's listening, and people like
Yes.
yourself, or advocates out there, you're making a difference. Let me just say, Sarah says, I love Rosa's transparency.
Thank
What I
you.
want to give is encouragement. You aren't alone. Rosa, you aren't alone. Consider total
Thank
health,
you.
this company, as you take this uphill climb, and we will always offer you our resources to stand aside you.
Thank
We
you.
work in Memphis and South Florida. That is our two initial chosen market. We
Mhm.
have total health. We teach. We work with on the oncology field. We do medical education, and we just started a Seek workshop. You know what we had spoken
Yeah.
to you initially about, where we are trying to educate doctors on this very thing, on these same
Yeah.
issues. Memphis, as well as South Florida that you mentioned as well. And
Mhm.
so we are building out our nonprofit, the Cancer Equity Project. And people like yourself are people who we want to align with, because
Yeah.
together we know we're stronger, right? We don't want to reinvent any wheel. We want to
Yeah.
collaborate,
Yeah.
and coordinate stuff. So you're not alone. And I know we mentioned, I don't want us to hang up without talking about this, Rosa. We talked about we talked about the economics. We talked
Yes.
about you and I. We had an honest conversation
Yes.
about how we as Black people eat, or people of color.
Yeah. Yes.
We talked about, we don't want to go into the history of why we eat the kind of stuff that we eat,
Yeah.
because that comes from a real historical place 400 years ago or 200 years ago when we ate,
Yeah. Yeah.
the bad parts of meats,
We
right?
had to.
We got accustomed to eating tribes and
Yeah.
intestines. We got accustomed
Yeah.
to it, right?
Yeah.
But that's kind of what our great grandparents and that's kind of what they ate, right?
Yeah.
So, but we said let's fast forward as to why we're still eating that.
Hmm.
Now that
Yeah.
we know that that was more of a slavery type food. Why are
Yes.
we still eating it now? And we talked about the economics you saw there in Memphis, and you were talking
Hmm.
about in the neighborhoods that you work in.
Yes.
You're on the. Tell us about the stores. Tell us about what you're seeing in those neighborhoods.
Yes. Yes, so I wanted to backtrack just for 1 second with the I think with the changes is because some of our older doctors are transitioning out. And so some of the new people that's coming in is being based in school, like the education is being based in school, how to accept everyone where they are. And so
Okay.
we are seeing that here in Tennessee, like people, like even when I went through public health school, we have a cultural competency, we have to do equity classes. We're seeing it at the medical colleges here in Tennessee. So it's a lot being happening. Now, fast forward to where we are now. With
But that's a good point. I'm glad you
yeah,
mentioned that, because
yeah,
that's a good point. Which is good. That's encouraging, because you're saying that the old guard, the older doctors
yeah,
from
they're
where we started,
retiring. Yep,
they're retiring, and now
yep,
these newer doctors, they're having gone through medical school, they're now
yeah,
exposed to DEI,
yes,
cultural training,
yes,
equity training, and they're putting that into practice, and you're seeing the difference in.
yes,
That's wonderful. That's good.
yes.
That's encouraging.
We got to keep that going.
Yeah,
And
that is
yeah,
encouraging.
yeah, and so so I would say myself, I am considered a upper middle class African American individual. I stay in a nice neighborhood, all these things. But I sometimes like my greens, and I like a little bacon and a little, how my grandmother used to cook it, because we're in the South. And
Right.
so I know that it's bad, but the education, so myself, I have the education that I know that is bad, but we also have those individuals who think that is good eating, or that is healthy eating because it's not a bag of chips, or it's not a honey bun. And we have to get them to understand that your vegetables do not supposed to have a ton of salt in it. Your vegetables are not supposed to have fat back in it. Even it's good, but it's not supposed to. And we have to limit those intakes. And so that's what leads to the cancers and the diabetes in people of color, because that's what our grandmothers did. And it just gives you that homey feeling. It makes your heart feel good when you eat soul food, as we call it. It's called soul food for a reason. You can have those same pot of greens without all of the bad stuff in it, and it just won't hit the same. So I think that's just the cultural thing in us, because it's feel good food. So we just have to come up with ways that we can educate our community. And communities have different things that they battle with. Although ours may be the pork and the salts and stuff, other cultures have their things that may be bad for their health also, but they can't let it go because it's cultural tradition. And so just continuing to educate, to show people, okay, you can do this, but you can modify this, or you can cut it here, or you can, do these things to make you better. You can eat it once a week, but don't eat it every day. Or you can have it once a month, but don't eat it all the time. And so that's a thing. Another example, my sister, she's diabetic, has been diabetic since she was 22 years old. And she still, like, even though she knows it's gonna make her sick, she still has to get some piece of pork chop or something in her mouth, and she knows it's not good for her health. But that's where the education comes in and say, okay, you can eat it, but don't eat it every day, because we know that we still have to take that blood pressure medicine. We have to make sure we drink enough water. We have to not drink a soda pop every day. And so just being able, especially because we don't have those options in our lower income, we don't have the education, it's not taught in school, and we don't have the options. It's a corner store. In my neighborhood, there's gas stations. They have the snacks, they have this stuff. At the corner store in the low economic pop communities here, they have, you can make get you luncheon meat, you can get pizza made, and EBT pays for it. And we know that's not healthy. They don't have a fruit section or a vegetable section in their corner store. And if we're gonna offer food options, it should be equitable everywhere. The corner store for those who can't afford to get on a bus and ride to get healthy foods at a grocery store, which is not fair. So we just need to be able to offer that everywhere, and not just those that are populated with people with money per se. It's not fair it's not fair to anyone, not even ourselves.
Very good point. We talk about the social, determinants of health, and we talk about the financial piece.
Yeah.
We talk about, I had someone else on, I think from Memphis. We're talking about, again, the neighborhood. You talked about the Hispanic situation, about the Hispanic lady who died from COVID, but it was really because what you guys saw was because she just didn't speak English, and they just couldn't be bothered. And so they didn't treat her the way they would treat an English-speaking Black person who could speak for themselves. There was just no one to do the translation. So they didn't, they just, so, all these things factor into why minority groups die at higher rates, even though when they think of breast cancer, where, white women get, they have more incidences of breast cancer, but Black women die more. And so it's all these things that we're talking about, and we have work to do. And, I'm certainly happy. We at Total Health, we're happy to be rolling up our sleeves beside, someone like yourself. I'll throw more questions out there, and then I'll let you close the session, because I told you it was going to be 15 minutes. It's already 31 minutes.
It got good.
So, quick question. Do you find that doctors of color are more responsive or more compassionate to people of color, or do we just need more training for all doctors? That's a good question.
So people say representation matters, and I am a firm believer that representation does matter. I feel that we are more compassionate to people who look like us, but I'm not a person who I feel all doctors should be compassionate no matter. We are all human. We all bleed. We are all related. We all brothers and sisters. That's how I look at it. I'm not going to treat, with me doing the work that I do, when I took a vow to say that advocacy was my ministry, that means I was going to treat everyone, no matter Black, white, orange, purple, green. If you bleed red, you're my human. So I think competency or compassion for response with all doctors matter. I do feel there's and that's what any race, I feel they're more compassionate with people who look like them. And that's just something that's human nature. You're more compassionate with someone who looks like you, and you feel like y'all have the same journey. But I do think it's important that we provide training to show that everyone should have that same compassion, even if they don't look like you or speak the language that you do. It shouldn't be a stereotype when it comes to healthcare. We need to stop doing lazy healthcare when it comes to humans, or we're in trouble. We have to start doing effective, and have to start doing the work when it comes to healthcare, when it comes to all humans, no matter how they look.
I agree with you. When you said, doctors or people, relate better to people who look like them. But why training is important for all doctors is because, it's the same way. If we have a Black doctor, we want him or her to look at a white patient the same way he would look at a Black patient, or look at a Hispanic patient the same way he would look at a Black patient. And of course, the reverse, for all races. Last comment here. Eye-opening and sometimes teary-eyed interview, Rosa. So Sarah is my other partner, the founder of Total Health, and who normally sits with me on Tea Talks. But even if she's not here on the camera, she's always in the feed. As a matter of fact, she's on vacation right now.
Love it. And she's on here talking to us.
She's supposed to be resting, but God bless her heart. She always supports this show because this is, the name Tea Talks was her idea.
Love it.
She said, I don't want this to be our last conversation. We will share the work you do and commit to help you. Great Tea Talk. And Ilana wanted to say that we are looking forward, hope to see you. We're going to be in Memphis.
Yeah.
June 17th. We're actually having it, and it would be wonderful if you could come. It's going to be at the West End, Memphis.
Okay.
Ilana will be there and other members of our team. Sarah will be there and other members of our team. It would be wonderful. And we'll talk a little bit afterwards. It's a free, and I'll send you a registration link for you to observe the program, even just the first half.
Yeah.
We're doing the training and the talks on disparity health,
I got to meet y'all in person.
Yes. And I'm going to be back. I won't be at this Memphis trip, but I'm back in Memphis in August for another diversity event.
Yes.
In Memphis. So we'll definitely keep in touch. So we like to end Tea Talk with something to leave with the audience. As I mentioned, Sarah, she came up with the name Tea Talks because of T cells in our body, right? These are the happy cells. So we'd like to give our guest the last word in, what can we walk away with that would, keep us encouraged, keep the audience encouraged. In our conversation.
So my thing, my TED Talk is encouragement anyway. I just, we are all in this fight together. It's not a one person's journey. I feel like when one person is impacted by it, all of us are impacted by it until we find an answer. And my goal is I want us to work ourselves out of a job when it comes to public health and what we do. I want us to work ourselves out of that job. So just remember that you are not in this fight alone. You have a sister or a brethren who's there to hold your hand and gonna talk for you when you can't talk for yourself. It may be you today, but it may be me tomorrow. And I hope that we could come together and you can be my voice just like I was standing to be your voice, no matter what.
Amen to that, Rosa. You were wonderful. We learned a lot. We certainly feel your passion. We feel, your purpose that God put you here on this earth for. You said that advocacy is my ministry. I use the word ministry a lot. I'm a person of faith. So ministry is huge for me. And the work that we do, honestly, we really need God's intervention and help. So I really appreciate your honesty, the work that you're doing. And we look forward to working with you in the Memphis area even more closely, now that we know you. So, all right, folks who are watching, and if you're watching the replay, leave your questions. Follow Rosa, follow her journey. Thank you for being with us here today. Take care.
Thank you.